Shilpa, I wanted to move on with you and go through this. This is the toripalimab data, disitamab vedotin plus toripalimab. It was at ASCO. It was out of China. I highlighted it as the Annals of Oncology top kind of, buried gem out of ASCO. And the reason why is, now, there are lots of caveats with this. The trial's not...
MIBC, right?
This is muscle-invasive bladder cancer, but they've reported a 61% path-CR rate. When you go into the detail of the trial, it's quite complicated because it's really immature, and they're only halfway through the study, and they've reported that. And so there are a whole series of patients on study which haven't been reported yet. And so strictly speaking, you can divide that by 2 and bring it down to 30% if you obey the Niagara rules. But I think that's partly unfair because the trial's not finished. It's just immature. But Shilpa, if that 61% path-CR rate, what impact, because we've got trials coming up with EV Pembro, EV Durva-Tremi, if you've got a 61% path-CR rate with EV Pembro, EV Durva-Tremi, what's going to happen to the field?
I think what could happen to the field and what might happen to the field is that we may move away from radical surgeries or any radical treatment to the bladder if we are seeing some really great clinical complete responses with these novel combinations, and we can probably avoid any radical treatment.
So not doing cystectomy potentially in some patients who are having clinical complete response?
Correct.
We're going to come to that in a second. Tony, do you have a question?
I have more than one question, but it's going to be fast.
Far away,
Okay.
Tony.
First of all, I do like your socks. Red would be better, like I'm wearing it. So there are 3 things you didn't address in Niagara trial, a study I do not like. I think history will show that Niagara potentially have done more damage to the field. Let me explain. The 2 things I would love you, maybe it's not completely in the paper, but future is what happened to the patient that didn't get cystectomy and the subsequent therapy for which we're going to address you and I in an editorial that's going to come soon. But the issue here with Niagara is that now we're married to durvalumab pre and post. It did not ask the question whether we need adjuvant therapy, yes or no. And potentially, drugs that are active in the adjuvant setting, maybe with a survival benefit, nivolumab, maybe pembrolizumab with more, won't be used anymore. We are married
to
one strategy.
Yeah. So let's just take that question first. So first, could we have done 3 or 4 arms in the trial? It would have been hard. It's a 1,000-patient study. The previous trial, the EORTC study that closed early, with only 150 patients in each arm. So I think embarking on a 3-arm, 1,800-patient study at that time would have been difficult, number 1. I think number 2, the adjuvant setting is, while I think it may be associated with a survival benefit, we haven't yet seen that. We've done 3 studies without a significant survival benefit. So I think it'd be wrong to say we don't know that. We do know that the adjuvant setting doesn't yet have a survival benefit. And then the third issue, which I think is relevant, is one of the things that we've learned in urothelial cancer is that giving therapy up front with immune therapy, leaving your drugs, your best drugs, in the locker, particularly immune therapy, associated with long-term durable remission, is a mistake. Maintenance of avelumab is better than second-line therapy. Waiting for second-line therapy with pembrolizumab is, I think, a mistake. And giving these drugs earlier is the beginning, in my opinion, of not a mistake, but the beginning of a new chapter where we might end up not doing surgery at all, and we could even end up curing urothelial cancer. Now, don't get me wrong, these other neoadjuvant trials may come and report, and they may be negative, and we don't yet know. But Niagara could be the first star to appear in the universe associated with curing muscle-invasive bladder cancer. And under those circumstances, Tony, people would look back at your approach, which is surgery followed by adjuvant therapy, as being somewhat archaic, because not only are we curing more patients with a survival advantage, we're also not doing cystectomy, and that must be seen as progress.
I partially agree. I'm going to rebut 2, and I think this is important. 1 was the ctDNA, and I agree fully with Andrea and the study you're dealing. This could have been different. The second thing is you may not need adjuvant therapy. The ideal study would be neoadjuvant with cisplatinum base versus cisplatinum base plus immunotherapy, And after cystectomy, when you get the result of cystectomy, you give the adjuvant du jour, whether this is, you know, gemcismore, gemcarbo, whatever you want, immunotherapy, whatever the adjuvant du jour. And in a large study, it doesn't need to be 3,000 patients, 800, 900 patients, you see what happened. And you answer forever the question of neoadjuvant. Niagara is good, but it stops midway.
But Tony, that's a cooperative group trial, right? That's an adaptive design cooperative group trial, right?
We work with a lot of industry. We could convince one, we convinced two to do the immunotherapy re-challenge, Tom and I. So while you are right, but it's not impossible.
But I would also add that for the ctDNA, we have not seen any data from Checkmate 274, even though it's been so many years out. So at least we saw that data for the IMvigor 010, and hopefully we'll see that for the Niagara at some point.
I have a quick question. The patients that did not undergo radical cystectomy in the Niagara, did they continue adjuvant?
So it's a mixed bag of those patients. And I think that the detail of those patients, I hope we're going to present at ASCO GU. We've looked at it. One of the really disappointing things about those patients is the commonest reason is patient choice. And I don't think that's, you know, what is that choice? What does that conversation look like? Why don't they want cystectomy? What I think is intriguing is we will look back and try and correlate the PathCR results or the response results, if we can, some of the radiological response results with those patients, get real granularity about that decision. One of my concerns about EV Pembro is so active, we feel, that patients, I think, will say, hold on a second, I want to have a cystoscopy before I have surgery. And that's going to cause chaos in the trial. Because if they have an event, and that counts as an event, the winners will be the losers in the trial, and that's going to create a very grey result. And in fact, if I was designing those trials tomorrow, I would just say, go for OS. Don't worry about EFS. Because you're going to have OS. You haven't got OS, you've got to beat Niagara. And so get OS, and don't worry about this EFS, which, by the way, might not be working in your favor.
Or as Andrea pointed out before, rediscuss with FDA the definition of event-free survival. In that study, the Niagara trial was about 6% in one group and about 7% in the other group that selected to not undergo radical cystectomy. And that may have impacted PathCR and potential, as you said, event-free survival, because they count as events. So I would love to see in my wish list what happens with those patients, as Andrea pointed out. And the question is, should we harmonization across those trials, should those count as events? Can we, of course, design future trials? To Tony's point, I think Niagara is a step in the right direction. It captured the idea that we need perioperative therapy. In the future, if we try to design a trial today, we can think about this cooperative group potential design with 3-4-arm trial, but 6-7 years ago, this sounded like a gigantic effort. So Niagara is in the right direction. I think there will be over-treatment. I think there may be under-treatment too. So until we define better biomarkers, ctDNA is the most promising. We need more work and more data. For now, we take the Niagara as a sandwich approach, but we definitely welcome more data from Niagara and the other ongoing trials to inform that adjuvant therapy decision in the future.
So two quick points. So one, I don't know if I completely agree with your comment about patient choice. I think the fact that patients are making these choices is real life. It's happening on the ground. And I think to have it reflected in a trial, I think is actually a good thing. That's the first point. The second point, I think we're in a little bit of a challenge right now when we think about bladder-sparing or trimodality, whatever you want to say, because if you think you have patients who have neoadjuvant chemo, then they get cystectomy, then they have the opportunity for adjuvant IO. Now you compare that with patients who are getting bladder-sparing, there is no adjuvant IO component to that. So the fact that some of your patients who didn't get surgery did get adjuvant IO, I think is important and will be important data for us. We've seen that even in Matt's trial, where again, patients who chose to not have their bladder taken out because they had a complete clinical response, again, they went on to get adjuvant IO as well. So it's trying to sort of, harmonize even between what we're doing with patients who have cystectomy, but also those who have bladder sparing, and I think that'll be important. So more and more, I think patients are choosing to keep their bladder. We need to reflect on that in our trials and in our practice.
Fabulous. This is the VOLGA trial. This is ctDNA analysis for durvalumab, tremelimumab, enfortumab vedotin. Only 17 patients, but very premature. But ctDNA analysis using a different technique. This isn't Natera. This is GRAIL, and you've got ctDNA clearance in 70% of those patients that were positive. I wouldn't overinterpret this, but your path-CR rate of toripalimab plus DV of 61% and your ctDNA clearance rate of 70% points towards the results of EV-Pembro and EV-Durva-Tremi being very positive. Now, whether they are or not, we'll have to wait and see, but I'm quite encouraged by that.
But comparing pathologic CR and ctDNA are completely different things,
Yes.
right? One is local, what's happening local, which may not be important for systemic disease versus systemic disease.
I prefer ctDNA analysis.
Me too.
Oh, you do? Okay, great. We've got somewhere. We agree on something else. Carla, you wanted to talk about Sunrise 4.
Just one quick point.
Yeah,
on
we're
that.
getting very quick.
That will be interesting to see Niagara and the other trials to see the concordance between path-CR and ctDNA. I may be wrong, but I predict that the majority of path-CR patients may have ctDNA negative, but would need to see that data, to see that concordance and whether that
But not always. And the
correlates.
reason not always is because it may not be systematically relevant disease.
That the local and systemic.
Systemic relevant
Carla, you were
disease.
keen to talk about Sunrise 4.
Yeah.
Sunrise 4, do you know about it? You're far away.
I know about it a little bit.
Yeah.
I mean, really, it's looking at combining an immune checkpoint inhibitor and TAR-200, which is this cool kind of pretzel device that elutes gemcitabine locally. So this study really looked at TAR-200 plus citrilimab or citrilimab monotherapy. And I do notice a number of patients here were refusing neoadjuvant chemo. I think it's an important point to keep in mind. The point I was going to raise with this is, we talk a lot about pathological complete response rate. And does a pathological complete response rate with an agent that's giving gemcitabine locally, is that the same as a pathological complete response with someone who's getting neoadjuvant chemo? And I don't think we know the answer to that. And I'd be curious to know if ctDNA could play a role in trying to understand this a little bit better as well.
Does the pretzel, does TAR-200 have any role in muscle-invasive bladder cancer if the neoadjuvant systemic therapies are mopping up the disease effectively, getting rid of the MRD? Does local control make any difference? Under what circumstance do you see Sunrise 4 and TAR-200 having a role to play in muscle-invasive bladder cancer?
I would say that in this, it's not just the local control. When you combine it with the checkpoint inhibitor, you are getting the systemic control too. And if as you can see here, 61% patients refused cisplatin. So I'm assuming they were cisplatin eligible, or I don't know, but that would be assumed. And if you're getting systemic control with the immunotherapy, getting good control with TAR-200 and sparing them the toxicity of cisplatin-based systemic chemotherapy, I think that'll be big. But again, this is a smaller study. We'll need to see phase 3 study.
Petros convinced me that TAR-200 in the future, even if these trials are positive, has a role to play in muscle-invasive bladder cancer.
It will be a hard one. The reason is because you mentioned the Volga trial and Keynote 905 in cisplatin-ineligible patients. We have to wait for the data, but the assumption is these are very likely to be positive trials. So the question is, how does this fit in the context of those two ongoing trials in cisplatin-ineligible patients? Will be a hard competition. I suppose patients who, number one, may be ineligible to get those drugs systemically, which is a very tiny proportion of patients, maybe less than 10%, might go with a local approach, or those patients who do not want to risk having systemic therapy, I think will be a hard competition in the context of Volga and Keynote 905. Although the drug is very active, as Kala mentioned, it's impressive, but I predict it might have a role soon in non-muscle invasive disease.
I have a comment. I think that it will play a role for bladder preservation trials because you've got great systemic therapy that we are moving into the perioperative space. And if we can control the disease in the bladder, then we're golden.
And these are the next generation of trials, to Tony's point, what Andrea mentioned. As we get better and better with systemic therapies, effective systemic therapies, pembrolizumab, enfortumab, and others, Volga regimen, are we going to be in the point to cure more patients by introducing systemic therapy earlier at the stage of micrometastasis, Tom, that you alluded to? I think we're getting there. I think, Kala, you mentioned us before. The big question is, can we develop clinically useful biomarkers to identify, select those patients who have long-term remission with bladder intact? That's the future. We're getting there. We're not there yet, but we're getting there. The Hoosier trial by Matt Galsky goes in that direction. The Retain trial is also in that direction. So I think we're getting there in the future. Maybe systemic therapy alone in selected patients with reliable biomarkers.
And I want to add, Tom, that they're not mutually exclusive. The EV-Pembro, if it moves in that space, or the Volga regimen, and if after that we don't do cystectomy and we don't do radiation, just put TAR-200 in to control local control, I think that would be really the future gold standard.